female autonomy as a predictor of early detection. And full disclosure, my project was proposed to look at cervical cancer, and due to the nature of the questions, and I'll get into that later, it is now on breast cancer. So just a little bit of outline of what I'll go over, similar to what everyone else has talked about. So globally, breast cancer is the leading cause of premature death and disability, especially in women, disproportionately is affecting women, and so we already see that there's a huge gender divide. Breast cancer is the 5th leading cause of death from cancer overall, but on LMICs and other developing countries, it's the #1 cause. And in India specifically, the age standardized rate of breast cancer has increased dramatically. And from 1990 to 2016, there was almost a 41% increase. So we're seeing that within LMICs and in India in specific, there's a huge issue with whether that is them coming in for screening initially or just overall presence of the disease, but we're seeing that there is an increase. In India, the healthcare system is very overburdened, whether that be at the local hospitals or even in the private sector. There is just not enough human resources to go around to treat and to prevent diseases of all types across the country. Women in particular, there's a lot of gender discrimination and a lot of gendered roles that women are supposed to fall into, and so when it comes to healthcare, they really are underserved. There's a lot of stigma and just in general unequal access when thinking about the severe roles and gender roles that women are supposed to be or confined to. From the NFHS survey, the National Family Health Survey, which is India's version of the DHS, 9.8% of women have been screened for breast cancer. And the schemes that are currently in place that cover, so the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, which is a really comprehensive NCD prevention program and scheme that offers prevention and treatment for NCDs. It covers all of those, but it doesn't really give emphasis to any one of them. In 2010, cancer was reintroduced to this scheme. Initially, cancer had its own, the NCCP, and it was its own scheme that was particularly for the prevention of cancer. And to consolidate, they put all NCDs together as like a big push from WHO in emphasizing NCD prevention in LMICs. Within this, we did see that there was a big rollback of the efforts and money being put into cancer prevention. Recently, about 2 years ago, India introduced the largest public health care scheme, and it's been dubbed Modi Care, and so each family that's under the federal poverty level can receive up to $500,000, so roughly $7,300 to use for any sort of secondary, tertiary care, but that's per family. So your family might have 3 family members, or you might have 10, and for those 10 people, you're to use that $500,000 of rupees to pay for any sort of secondary, tertiary care. But thinking again of how overburdened the healthcare system is, that money isn't going to go very far, and if a woman is to be diagnosed with cancer versus a man who is working full-time to support the family, you can kind of see how they're going to negotiate to spend those monies. Female autonomy is a really overlooked intermediary factor that links these inequities to poor health outcomes of women. Being able to make decisions and have autonomy over your person and your position in the family really is going to dictate if you're able to receive such services. So even if you're at risk or you're not at risk, having the autonomy and the ability to make your own healthcare decisions is often overlooked. It's defined as the capacity to manipulate one's personal environment and to really obtain information and to be able to make decisions about your own health. So for my study, I wanted to determine the extent of which female autonomy plays a role in early detection, originally of cervical cancer, but shifted that to breast cancer. So coming down from that, my aims were to develop a multifaceted measure of female autonomy by indexing questions from the pre-existing NFHS4 survey, which was I'll get into the specifics of that. And then I wanted to assess the relationship between female autonomy and women's utilization of these preventative breast cancer screening services in India. So I conducted a cross-sectional study. I utilized data from the NFHS4, which was collected in 2015 and 16. It's nationally representative of every state in India and the national territories and union territories. There was a ton of women that were interviewed, and they used a 2-stage clustered sampling method, so having to account for this, the sampling method in my analyses, and I ran bivariate logistic regressions. You can see how I got to my final analytic sample size. I'll get more into the modules and why the domestic violence module was one of the criterion, but I did make sure that women were married and living with their husband, just to add another layer to understanding autonomy in that household. And then accounting for people being over the age of 30, the Indian Council of Medical Research, ICMR, suggests that women start being screened for breast cancer at the age of 30, because in India, the average age of onset and prevalence of breast cancer is much younger. It's usually 35 to 40, so about 10 years earlier than in Western countries. So 30 is when they start to suggest you start with clinical breast exams, and if you are at risk, to move to mammography if available. To measure autonomy, I indexed 21 questions to come together with a full autonomy scale. And within that, there was 4 subscales. So usually autonomy is looked at through indirect predictors. So looking at education and working status. And so things that are very like, would they have the ability to make these decisions and pay for it or have the knowledge to. Direct are a little bit different in looking at, do they have the autonomy economically to make decisions within their household and have the money to do so? Are they making decisions about their family and their health? Community involvement, are they able to go out and go to the market alone, or do they have to have someone with them? And freedom from violence, which pulls in that domestic violence module. Only a handful of people were asked questions in that sampling strategy about domestic violence and attitudes towards violence. And because it is one of the major predictors of autonomy, I had to limit my sample size to include women who are asked those questions. Overall, the autonomy scale had pretty good internal reliability, but this was the highest of any of the papers that I read that were looking at female autonomy. There's not a great measure, and using what was in the NFHS to kind of pull this together, a 0.71 was pretty good. So just for some demographics, the overall sample size was 35,699, and the mean age was 38. Average household size was 5 people. As majority were middle to lower class. There was 42% that were in that high wealth index, and 39% had received no formal education. So we see that there's already kind of, aside from that SES level, looking at education that is pretty undereducated. And of this sample size, only 14% had been screened for breast cancer. So initially in my unadjusted model, I was just looking at these the 4 subscales in the overall autonomy scale to see what was maybe predicting if people were going to be screened for breast cancer. So initially, it was just economic autonomy, but it had an interesting way of kind of playing out. So we saw as economic autonomy decreased, they were more likely to be screened, which you wouldn't necessarily think. So it kind of brings in information and data that weren't collected. Where were they getting the screenings? Were they local camps? Were they going through community healthcare workers? Or were they going into private clinics, into a practitioner that they go to regularly? A lot of these schemes and a lot of the efforts that are being pushed in India focus on low-income women and people that have low education, so it would make sense that they would be the most likely to be screened. But still, there's a lot to tease out. Moving into the adjusted model, I did a state fixed model, knowing that India is a very diverse country and every state and union either has their own language or their entirely own country. So to kind of account for that, holding all those states constant, but also adjusting for age, wealth, caste, religion, household members, education, insurance coverage status, and also like rural, urban. Again, we see that the economic autonomy is still statistically significant, although it is slightly decreased. And we see that freedom from violence is now playing a role in showing that as that autonomy decreases, they are less likely to be screened if they're not as free from violence. So the more violence a woman may be experiencing, the less likely they are to be screened. It does make a bit of sense if you are not able to go and any sort of connection with people and you are being very isolated, as that is a huge aspect of domestic violence, being put into isolation, then you wouldn't be able to go and be screened. Additional findings, as expected, the wealth index was also very predictive, as was education level, and insurance coverage was as well. And so it brings up the question of what type of coverage did people have? Because there was questions about, was it a public assistance insurance scheme or was it private? A lot of private insurances will force, especially with people women shifting into these career roles and being able to have insurance, a lot of these insurance groups and people that are hiring them will force them to get a full physical, and so they're required to have these types of screenings once they hit a certain age. So that might also be playing a role into that insurance coverage and how it is being a lot more predictive. Just broad conclusions, the relationship is very complex and really needs a lot of further investigation. I think in India, people often think about how women and men are separated and the roles that women are to take, and just a lot of work has been looked at it in terms of cancer. There also needs to be a need for a more accurate measure of female autonomy. I've been, over the summer, working on this project. I was able to connect with a lot of folks from all over the US and all over India that are really trying to refine how do we measure autonomy and what does empowerment look like as we move into this broader global landscape of empowering women and really realizing the potential that they have to improve everything in general. It also gives a lot of insight to the role that gender-based violence may play in the role in dictating women's overall health. A lot of times we think about violence as this one thing and mental health and a few other outcomes, but this tied, showing it to just cancer screening, it's an overall predictor of women's health and really trying to get at the root cause of that. In addition to this study, I was able to conduct another one that when I was doing the analysis for the domestic violence module or subscale, there's a really interesting finding that it was a really high acceptance of domestic violence. So questions about would it be acceptable for a husband to beat their wife if they burn the food, or if they neglect their children, or if they go out without permission? And it was roughly 50% of these women had said, yes, it's okay. To at least one of those. And so I did an additional analysis looking at unmarried women between the ages of 15 and 25, and the percentages were just as high. And I was able to compare between time points to look at this decrease in acceptance to see if these policies that have been put in place in India that are focusing on female empowerment, are they working? And so being able to track that over time. So there is a lot of ways to tie in gender-based violence and just violence work in general as a predictors of women's health. And in general, this is directly attached at the intersection of SDGs 3 and 5, health and well-being and gender equity and equality. They're completely tied, and this is a really easy example to see how it's predicting, and everyone that is presented about breast and cervical cancer has just given more and more evidence that this is something that is really important, because it's not just the women themselves, it's the whole family unit and the communities that they're a part of. Strength, so I was able to look across various subscales. A lot of times people don't do that. It's pretty difficult and it's very tedious. The NFHS has roughly 2,000 questions, so I really went through and was talking with people who have worked with the data set very closely, and with Population Council. I'm plugged into their India office, and they have a group called Rasta, which is for young researchers doing data analysis with NFHS data, and they were able to give a lot of feedback and provide me with insight to questions that may have been relevant, and also along the way to really plug me into other researchers that are doing work like this. There's also been very little research on autonomy and cancer screenings. I found one study that was done that wasn't very strong, but it was published and it was out there, so I'm curious to see how this conversation moves forward and taking just female autonomy as its own thing and predicting some health to how is it really tied to behaviors. Limitations, a lot of the questions were very sensitive, and so interviewers and social desirability bias may have been there with these face-to-face interviews from the data collectors, and also the data quality due to how questions were asked. So I couldn't really use the cervical cancer questions. I don't expect anyone to read Hindi, but if you can, in the first question, in the parentheses, that's just the phonetic spelling of cervical, and the word before that is the word for womb. So when they're even asking the question, there's no word to tell people exactly what they're looking at. So the cervix isn't the womb, but cervix doesn't necessarily mean anything to them in Hindi. So it was really difficult to try to figure out what they were asking. And it doesn't actually ask about screening, it asks if it's been examined. So the question when it comes to cervix, it could be, yes, I was examined because I was going to give birth. I was going in for a prenatal visit, and so that my cervix was examined. So for those reasons, I had to shift to look at breast cancer because examinations of the breast wouldn't be as confusing. There would really only be one reason that you would be going in for those exams. So that's something that's being worked on. I was accepted to present a poster on one of my studies that I did this summer in India this October, and have received confirmation that I'll be speaking on a part of a young researcher panel on like how we can change questions and how do we get plugged in to people using this data to make it really meaningful. Because right now there's a huge push for NCD research and the questions aren't capturing what we need. So I'm really excited to go in and share what I've found, whether that be through my field work that I had previously done as a Fulbright scholar after my undergrad before coming to Michigan, which looked at barriers to cervical cancer care and stigma towards screenings and diagnoses. So just trying to tie this all together and now moving forward into a more professional career as a researcher, being able to bring those together. Future directions, I'm in the process of doing some multi-level modeling and looking at how these clusters of subscales might be predictive. And so taking a little bit more, since nothing was really significant, seeing if there's particular types of clustering at the community or at the household level that might be more predictive of this cancer screening, and what might be. So if it's a lot of economic stuff, it might be in one community within one state that is a lot, that's more rural versus another, and more urban, it might be more domestic violence or community access. I'm also interested in looking at the insurance types to see if there's a difference in screening prevalence by insurance, and also utilizing other data sets that would have more information. I'm looking into the SAGE data set. It's a little bit older, but there's a lot of really good information there, and a lot of researchers that have suggested that I do that are willing to help me kind of explore that as I move into looking into capstone things for my program, so I can further explore this. I also think it would be really interesting to assess health systems by tracking progress. So India, every state gets to choose when they implement these programs and these schemes. So if we look kind of and stagger where people are starting and at what point and what time point after implementing these programs the screening progress is. So taking a really health systems approach to looking at it. Overall, my learning experience was absolutely wonderful. I worked with a biostatistician. No, this is not working. So this side, that's was my preceptor, Arpita Ghosh. She is at the Georgia Institute for Global Health, and it was so great to work with the biostatistician and learn how, as an epidemiologist, I am to work with the biostatistician. And I brought a lot of the ideas and a lot of the grunt work, and she gave me all of the expertise and a lot of grace and taught me a lot more beyond the courses that I'm currently taking and that I'm going to take. So I'm entering my second year with a much higher level of understanding of statistical analyses and how I can really apply this, especially as a social epidemiologist. I also was able to tap back into the Fulbright network as I had lived there before, and so I helped with orientation to orient the new Fulbright scholars coming in, and was able to meet with lots of people from the embassy and really emphasize the importance of Fulbright and the program and what that has done for my career. I also was able to reconnect with my advisor, who's above, Sunitha Krishnan. She is the director of MLE for the Gates Foundation in India. So I was able to shadow her in the Gates office and follow along to a lot of meetings. And so that's really expanded my professional network, and being able to go back in October and again check in at the Gates office and connect those folks with people I've been working at the Georgia Institute. And then I was able to reconnect with friends that I used to work with at my old host institution who I'm still on ongoing projects with. So it was really great to go and wrap up papers that we were working on and just really emphasize working in India is not easy, and so much of it relies on community and having those connections. And I was able to go back and be welcomed and have really high expectations that my Hindi was still as good as it used to be. So really put a lot into perspective, and what does it mean to be a global health researcher, and how do you build those relationships and continue to strengthen them? Future goals, I'm applying to doctoral programs this fall to a broad range, epidemiology, sociology, and implementation science. I still want to focus on the intersections among gender equity, health promotion, and women's health over the life course, but I am really interested in cancer. I'm not necessarily as interested in cancer as a disease so much as an outcome of social and other disparities. So just a little very social epidemiologist. And I plan to continue my global health work in India long term at this point, knowing the language and understanding, having traveled and lived there for such a long time, it makes a lot of sense. I never anticipated doing that. I grew up on a reservation in central Washington, so to end up in New Delhi, India is far beyond expectations of my community, but it feels like home, and I'm really excited to see what will come from not just this summer, but my previous work and moving forward. What is that going to look like? Because right now there's so much there and it's really exciting. Yeah, so thank you.